Welcome back, Peter C2 here, starting on part 2 of 4 for hard disk rate remote afterloaders and NRC regulations. We're going to be talking about design and safety features that you would see in your remote afterloader system. So radiation safety and control is a huge component of this system. There are many redundancies and numerous safety checks that happen. So there are safety features inherent in the remote afterloading unit that we'll talk about. There are initial radiation surveys of the facility and subsequent patient surveys, and each one of those surveys is completed after each source exchange and after each patient. There are routine precautions that are required during normal use, such as signage and the lights being used to indicate that the source is out. There are precautions taken during source exchanges. There are emergency procedures and training and the retraining of personnel. So some of the design safety features of the afterloader unit. A battery backup system must prevent the loss of the data during a power failure. Ideally, it would also allow a power interrupted treatment to continue. There is an interrupt button that allows the treatment to resume after a planned interruption. Should you need to go and address any medical needs or adjust some part of the patient's needs not related to the afterloader or the applicator itself. There's a simulation mode using a dummy source to test the source guide tubes and applicator clearance immediately prior to the treatment. So whatever distance the source is going to travel out to, there is going to be a dummy or a test source that goes to that distance prior to make sure the path is clear so there's no obstructions. Number 4, there's a clear console indicator that shows when the source is in and out of the safe, and there's a room indicator that shows when the door is open or closed. And there's a last resort safety system for manually returning the source to the safe in the event of the other electrical source return mechanisms fail. So in addition to having electric return mechanisms, there is a manual return mechanism, and there is always a safe to place the applicator into should you need it. These are several of the displays for both the Gamma Med and the VeriSource applicator systems from Varian. Starting on the left, the in versus out app identifier is given as orange when this is when the source is out and illuminated, and then the cross through the yellow when the source is in the safe. The key indicator goes from off to program to treat, and then there are emergency offs at various points throughout the system and on the back of the remote afterloader itself. The emergency source retraction arm, or the hand crank that's used in the last resort, is located on the side of the VeriSource and on the back of the Gamma Med, this surface that's facing away from us. Each of those allows you to take the source cable and manually crank back all the way to the safe position. Upon the installation of the afterloader in the source, you're going to be doing some checks, and those checks are initially to demonstrate that the shielding is adequate for the general public and those who are occupationally exposed workers. Those checks of the shielding are performed typically every quarter to verify consistency with the initial results, and the checks are also done on every patient to make sure that the pre-treatment and the post-treatment value for exposure is the same, and which is near background, whatever the patient's background happens to be. So it's occasionally there is a nuclear medicine patient that shows up in the department for an HDR, and so their background is a little bit higher than the rest of the background. For uncontrolled areas of the general public, we need to see that the exposure is, the dose equivalency is 100 milligram per year or less, and less than 2 milligram in any 1 hour for the calculated shielded dose equivalency. For occupationally exposed workers, it's less than 5 rem or less than 5,000 millirem whole body with specific limits to organs. There are ALARA, these are the regulations. 10 CFR 20 describes where those numbers need to be. Those numbers are the same as the other parts of the hospital as far as protecting the general public and what the limits are to exposed workers. ALARA action levels vary from facility to facility, but are typically on the order of 10% of the limits. Among the routine precautions that are part of the HDR, the afterloader system, are the emergency safe and the long-handled forceps. And additionally, there are some sort of clippers or wire cutters that are attached here. The wisdom on cutting the source has gone back and forth over the years. The vendor's current recommendation is to not cut the source wire if you are having some trouble getting the source to retract, to remove the entire applicator and place the entire applicator inside the shielded safe. The containers are made large enough and deep enough to fit the entire applicator. This is an example of a pig that would be used to contain one of the safes without the applicator attached. In the event that you would need to close off a room for a source being out of its shielded safe, make sure that you have a survey meter and signposting. The door should be locked if possible, and if indicated, to put a do not open or do not enter sign based on your state or federal regulation. Posted emergency procedures addressing the correct sequence of events in case of a source not retracted are required at each of the consoles of the afterloaders, and they also should have contact information for all the emergency personnel, including the radiation safety officer. The American Association of Physicists in Medicine has suggested postings for operators' manuals at the console. The manuals describing the functioning of the control console should be close by to make sure that we have any reference information at the time that you would need it. There is a description of how to program a treatment just in case, and a description of how to check the program in time against some sort of factor in the case that you're using a decay correction factor as opposed to an individual plan for multiple fractions treatments. The emergency procedures, what to do in case that the applicator does not allow you to retract the source, or if the source becomes stuck in some sort of out position. The names and the contact information for all the personnel in case of emergency, including the vendor, the Nuclear Regulatory Commission, and the Radiation Safety Officer, and a checklist of QA procedures to be performed should be available at the console, and a list of error messages, if applicable, should there need to be some interpretation. One feature in using Iridium 192 high specific activity that will have to be accounted for on nearly a quarterly basis, typically 3 to 5 times a year. Most facilities opt with a quarterly, is a source exchange. So the source that's attached to the wire is actually removed from the machine and replaced with a newer, higher activity source. So a procedure for receiving and returning sources should be found in the department and or in the hospital network, and the frequency of leak testing. So this is a question that comes up from time to time. If it's a sealed source, does it need to be leak tested? Well, it needs to be leak tested on a frequency of at least every 6 months. During the point of calibration, the source is actually leak tested by the independent radiopharmacy or the manufacturer, and it's not required that the end user perform any sort of leak testing, assuming that the source is gone within 6 months. So if the source remains within inventory greater than 6 months, then leak testing is required. Frequency of inventory checks every quarter, and the specifications of the radiation surveys. So for the source exchanges, you will replicate the initial commissioning survey of all of the areas adjacent to the vault to make sure that that singular exposed source gives you a consistent result, maintaining the levels to the general public as low as reasonably achievable. And insofar as training, the course for the afterloader system should thoroughly review the available applicators and their proper use. So if you're going to be using the Savvy applicator, it's nice to have the rep come out and provide some insight into the measurement and the removal of the device. Number 2, the functioning and operation of the unit under normal conditions. I think that the vendors do a very fine job of making sure that there is normal use training. And number 3, the function and operation of the unit under emergency conditions. Once again, field service does an excellent job describing the emergency conditions and what to do in case a source is stuck out to reduce the exposure to the patient and the medical and technical staff to as low levels as possible. All safety features, including the disconnection and misposition indicators, radiation protection procedures, how to keep the general members of the public safe, and suggested QA procedures for the positioning indexer and for the activity of the source, and the aspects of the dose calculation system are if applicable. So training courses initially should be had for all of these. There is an annual training refresher required for the afterloader's emergency procedures. So you should be keeping up on the educational part of the afterloader training. The Nuclear Regulatory Commission requires that you have at least an annual training in the emergency procedures of what to do when the source stays out or stuck in an applicator. Thanks for paying attention. Part 2 is just about over. A few questions to make sure that we have just a background, and we're moving on to Part 3.